of you may not have. It's basically, this is one of the, this is how it looks like. So it has a probe जहाँ पे arterial blood यहाँ पे डाला जाता है, and then it is measured. So principle wise there is not much. It is basically a potentiometric thing. There are electrodes which measure the various levels that are there. So principle wise आपको ज़्यादा तकलीफ नहीं होगा. It is basically measures the partial pressure of oxygen, carbon dioxide, and mainly the pH. It's like your pH meter only with selective electrodes for oxygen and CO2. So these are specific electrodes, and if you see, it measures mainly three things: the pH, the CO2, and the oxygen concentrations. Other than that, there are many other values that you will see. So they are calculated. So there are measured values and calculated values, right? So if you see, normally you have pH, PaCO2, PO2, 5-carb, oxygen saturation, electrolytes, so on. Beside ranges, this is basically an example of what it looks like. Finally, it also gives you whether there is a anion gap or base excess or deficit present. Yeah. So the ABG analyzer pH electrode measures the potential difference between the measuring electrode, contacting a sample with H plus ions with a permeable membrane and a reference electrode. So this is basically a pH meter. So that is where you have the pH electrode. Similarly, you have an electrode for carbon dioxide and oxygen, right, which measures the partial pressures of both carbon dioxide and oxygen. Right, so the Clark electrode is commonly used for oxygen. Then there are calculated parameters. In addition to this, there is oxygen saturation, base excess, and bicarb. Each electrode needs to be calibrated with reference gases or buffer solutions. Temperature, ABG measurements are typically made at 37 degrees. And some ABG analyzers also measure electrolytes, metabolites, hemoglobin levels in some of them, right? So ABG analysis assesses oxygenation. We know all this. One of the things is when you're talking of ABG analyzers, there are certain pre-analytical variables which can give you false values, and we should be very careful how the sample is collected, how much time gap is there between collection and testing, under what conditions it is transported, and finally analysis. And many times from the report you realize whether it is arterial blood or venous blood. You know the difficulties. I mean, during internship you may have done ABG collections. They are not very easy, and neither easy for the person collecting nor easy for the patient because they're very painful also. Many times while collection you also get blood. Right.
Excuse me, sir. So the presentation is not showing on the screen.
You are not able to see.
The presentation is locked. Yeah, the presentation is locked actually. The slides are not moving.
The slides are not moving. Wait. यहाँ पे तो सब मूव हो रहा है. रुक. Okay. Oh yeah. Let me see what happened there. Sharing and presenting. Let me just fix that. Wait a second. This one, only one, yeah. Try to entire screen. You can see this right now, yeah. Hello, is this visible?
Yes, sir. The slide is visible, but the presentation is not. The second slide and the further slide is not.
Okay, if I do this slideshow, let me just check. अभी फुल स्क्रीन हुआ? या
sir, full screen. Yes.
अभी आगे बढ़ा?
Yeah, yeah, okay, okay. Right, sir.
या
Okay, sir.
या ओके, सॉरी, राइट, या. So the principle, basically what I was saying is it is the same as pH meter. Only thing is जैसे pH में H plus आयन के लिए रहता है, वैसे ऑक्सीजन का एक इलेक्ट्रोड है स्पेसिफिक, कार्बन डाइऑक्साइड का इलेक्ट्रोड, and that is where we are measuring the partial pressures of oxygen and carbon dioxide. Other things like base excess, electrolytes, these are all, I mean, electrodes, there are ion selective electrodes also. And bicarb is something which is calculated and it is not measured, right? Yeah. So mainly there are 3, 4 electrodes: pH electrode, carbon dioxide, oxygen, and ion selective electrodes here. But they are direct. So that is one difference when you compare the values of your autoanalyzer electrolytes and ABG machine. The ABG machine uses a direct IAC, whereas the autoanalyzers have indirect IAC. That means there's a dilution which takes place in the indirect ICs. So from accuracy point of view, direct electrodes are much better and more accurate as compared to indirect IC. So this is what I was saying. The analyzer measures the values of pH, PCO2 and PO2 and calculates other important parameters like oxygen saturation, base excess and bicarb. Okay, it needs to be calibrated, and some analyzer also does electrolytes, metabolites and so on. So here you realize that whenever ABG analysis is being done, collection is important, transport is important. It needs to be done under, I mean, too much exposure to atmosphere is going to, if there's a bubble inside the syringe that is there, it will affect your final ABG values. So there is a analytical phase and post-analytical phase. So these are basically a workflow where there's test ordering, selection, patient preparation, and all these things are there in pre-analytical phase. There are errors which can get in mainly because of bubbles, which can artificially increase your oxygen saturation and decrease CO2 concentrations. If the anticoagulant is too much or too less, again, it may affect your pH and other parameters in the sample. Delayed analysis, again, exposure to atmospheric air can again alter the accuracy of the ABG. So you have to be very careful and it has to be done under stringent conditions, proper syringe with a ice pack if it is not being done at the same level. Whenever it is being transported in a heparinized syringe, remove the bubble and so on. Other analytical errors may be due to lack of calibration. Sometimes ABG analyzers need to be calibrated frequently, where if it is not done, you're obviously going to get erroneous values. There may be problems with the membrane, improper sampling, clots, hemolytes, lipemic samples, all of these can impact. So how do you get a workaround for all this? Is you have to do daily calibration, you have to maintain the QC logs. It is not something which is optional. It has to be done every day. Otherwise, you won't be able to be very confident of your values. So elements of good quality, like any other analyzer, proper maintenance, control material, verification of linearity, all these things are important. Yeah. There is also proficiency testing, and there are set acceptable criteria, benchmarks, which says that if your ABG machine is working well or not. So your pH should be within plus minus 0.04. So the significance, obviously, it is like any other autoanalyzer that you use in biochemistry. Post-analytical errors like mislabeling, delayed reporting, all these things are there. I'll not spend too much time here. There are factors which can impact your ABG results: staff proficiency, stress in emergency situation, and all these things are there. So it's a point of care, and although it's point of care, that means it is not going to be positioned in main central lab. it is going to be, I mean, the place of any point of care device is near the patient. So most of the ABG analyzers are going to be near the casualty or the ICU, where you have critical patients and you need ABG monitoring. Right? Clinical interpretations are often challenging, especially if there are mixed acid-base disorders, and then there are chronic conditions with acute imbalances. So you can have these kind of strategies. Is it acidemia, increasing PaCO2, reducing bicarb, there's increase in carbon dioxide, that means probably it's respiratory acidosis. All in bicarb, mostly it is metabolic acidosis. Although it's not so simple, these are broad kinds of rules that are there. So when you look at the actual normal levels and cutoffs, you have uh, acidosis or alkalosis, either respiratory or metabolic. Along with that, you have compensation. So respiratory acidosis is going to be compensated with metabolic alkalosis. Metabolic acidosis is going to be compensated with respiratory alkalosis, right? With increased ventilation, breathing. So it washes out the CO2 and so on. So this is how it works. If your machine, if you think your values are not proper, you would treat it like any other analyzer. You should have pre-analytical SOPs, case training. This is nothing new or different. So there are certain scenarios your patient is afraid that arterial puncture will be painful, becomes anxious, hyperventilates. Hyperventilation can cause washing out of your carbon dioxide, leading to a pattern which is suggestive of alkalosis, respiratory alkalosis. Right. Two samples stored for 10 minutes. Scenario two, red blood cell sedimentation is visible. One sample is mixed well, the other is not mixed well enough. And you have hemoglobin values in two different samples as this. So obviously, collection is an important pre-analytical variable. If it is not done properly, you may get false values even on your ABG analyzer. Third scenario, two blood gas samples are collected from the same patient. One is analyzed immediately and the other is stored for 25 minutes on ice, resulting in 5% hemolysis. Again, patient values, differences in patient values. The one that is checked immediately, you're getting normal potassium, sodium, everything is fine. Whereas here, you can see that there is pseudo hyperkalemia that has happened. Right? Similarly, two samples again collected from the same patient measured after 5 minutes. One sample is mixed and air bubbles are expelled, the other is not. You have atmospheric air bubbles which are there interfering with your PO2 levels. Sample without air bubbles, PO2 is 70. Sample containing air bubbles giving you a higher value of PO2. Right? So these kind of errors are commonly observed with ABG analyzers. Small air bubble is added to a blood gas sample and transported. Initial PO2 is this. After pneumatic tube transport, it increases to 150. Yeah, similar to what we just saw. Yeah. Then two samples are collected, same patient, again sample measured immediately. The pH is 7.4. Yeah, lactate and glucose values, the HbA1c values are, the plasma glucose is 97, whereas in the other one, it is different. This may be due to the difference in temperature and storage, where there is consumption. The glucose is consumed by the cells that are present in the plasma. Impact of non-immediate analysis. Obviously, cells utilize oxygen, CO2 is metabolized by the cells, and increased CO2 is produced. Combined effect of increase in CO2 causes decrease in pH, increases in hydrogen ion concentration due to continued glycolysis. Glucose is consumed due to glycolysis, lactate is again increased due to glycolysis. You draw a sample, but you do not mix it. Delayed mixing causes blood to form clots, blocking the analyzer. Again, you'll have wrong values. Your analyzer will stop working. So again, you'll have to probably do maintenance of the analyzer, flush it with heparin and see. So these are certain protective mechanisms which are needed for handling ABG samples and the instrument. Avoid clotting of the sample. Should be mixed slowly. You don't want hemolysis also. ABG samplers with small metal balls are available for easy mixing. Capillary samples are mixed by moving a stellate across the capillary wall. So different kinds of mechanisms of mixing are there in different ABG analyzers. Dilution during sampling from arterial line. If you are collecting from a central line, there may be dilutions which are happening. So you have to flush the line first, discard the sample initially that you're collecting, and then take the sample for testing. Right. So this is how this is an example where you have difference in your values in chloride and potassium because it has been collected from a central line. When using ABG syringe filled with liquid heparin, again, a lot of heparin is left inside the syringe. It will dilute the sample, cause the PCO2 to have a false low reading. So good practices is use self-filling syringes. Back in the day, we used to take heparin from the vial, rinse the whole syringe, and then leave only a little bit. After it's rinsed, it's thrown out, and then the ABG is done. So all these things can lead to false values if it impacts the. If it is not done carefully. Select pre-heparinized syringes, opt for blood gas syringes. So basically, it is the same thing where you can reduce the impact of heparin interference. Right. So you have to be alert. It's a very important test and needs proper handling of the sample, handling, collection, transport, everything, and maintenance of the machine. Coming to the second part, which is an important aspect, it is basically acid-base disorders. So when we talk of acid-base disorders, many times it is not just pure acidosis or alkalosis. Our normal pH ranges from 7.35 to 7.5. In primary respiratory alkalosis and acidosis, compensation is in acidosis it is metabolic alkalosis, and in alkalosis it is metabolic acidosis. Right? And are you understanding what I'm trying to say? So if the primary insult is a respiratory acidosis, the body will try to compensate by making metabolic alkalosis. Whereas if the primary insult to the body is respiratory alkalosis, body is going to compensate with metabolic acidosis and vice versa. So when the expected compensation remains in the normal range and uncompensated disorder is present, that means your values are not altered. That means it has not been compensated adequately. It is still in the abnormal range. If compensation moves outside the normal range but does not bring pH to the normal range, that means your pH is still abnormal, but your bicarb levels, your PaO2, the carbon dioxide, partial pressure of CO2, and oxygen, they are altered. That means it is a partial compensation which has happened. When compensation brings the pH into the normal range, that is when you can expect a full compensation to be present. It rarely occurs with the exception of chronic respiratory alkalosis. So only during chronic respiratory alkalosis, especially at high altitudes, you can expect a complete compensation to be there. That means pH is also in the normal range. And the other things, that is your partial pressure of oxygen, the bicarb, and CO2, they're not in the normal range. They are in the abnormal range. So basically, when you're talking of acid-base disorders, you're focusing on pH. pH defines the primary acid or base disorder. For example, if there is a metabolic acidosis, you will expect a fall in bicarb levels. In respiratory alkalosis, you will have a fall in PaCO2. So why does that happen? Respiratory alkalosis means you have to imagine a patient who is hyperventilating. So whatever CO2 is getting built up is getting thrown away by the patient because of hyperventilation. That leads to respiratory alkalosis, and that will effectively lead to fall in partial pressure of CO2 and an acidic pH. So the primary disorder is metabolic acidosis, because of which you have fall in bicarb, and the respiratory alkalosis is the compensation. So that is how the body is hyperventilating, right? So you may have seen or heard of the Kussmaul's breathing and those kind of breathings as signs in different kinds of acidosis. That is the body's mechanism to compensate for the metabolic acidosis that is there. So primary alterations in arterial carbon dioxide seen in respiratory acidosis. So normally it is between 33 to 45. There's a table for causes which we'll see later. Respiratory acidosis is primarily due to hypoventilation with retention of CO2. So what does that mean? Your CO2 is going to be more than 45. That is the upper limit of the normal. There is a fall in pH, acidosis. To compensate or counteract the CO2, there is going to be, I mean, because the CO2 is there, it is going to dissolve in your blood. You will have a elevation in bicarb, and PCO2 is there. Metabolic alkalosis is compensation. So the body will try to wash off this excess carbon dioxide. And in a typical scenario, the CO2 may then be within, I mean, still less than 30. Defines acute respiratory acidosis. It indicates a renal compensation or a chronic respiratory acidosis. That means the person has hyperventilated and removed all the CO2. Findings and clinical features, you will have somnolence, cerebral edema, cyanosis, hypoxemia, fall in oxygen. Treatment, treat the underlying cause, oxygen support, ventilatory support is basically the treatment that is given. Second part, respiratory alkalosis. Again, you have respiratory alkalosis characterized by hyperventilation or elimination of CO2. So partial pressure of CO2 of 12 milliequivalents per liter indicates a renal compensation and defines respiratory alkalosis. Clinically, again, you'll have lightheadedness, confusion, signs of tetany. So this is interesting. Why would you have signs of tetany? Does anyone know this with respiratory alkalosis? What does respiratory alkalosis have to do with tetany? So basically, it is written here, alkalosis increases the negative charge on albumin, and because of this, the calcium gets displaced from the ionized fraction and it gets bound to albumin. So you have less of free ionic calcium that leads to tetany. So if you measure total calcium, it will be normal, but ionized calcium will be less in respiratory alkalosis. So these are the causes of respiratory acidosis and causes of respiratory alkalosis. So when there is hypoventilation, respiratory acidosis, obstructions, respiratory acidosis, obstructions in the chest wall or the muscles, neuromuscular disorders, in respiratory failure, obstructions in the lung, COPD and all, ये सब चीज में आपको respiratory acidosis मिलेगा. Respiratory alkalosis, overstimulation, anxiety, high altitude, pregnancy, salicylate poisoning, hyperventilation due to pain, restrictive diseases, all these things cause respiratory alkalosis when they are washing out the CO2 that is there. So essentially what happens in alkalosis causes H plus ions to move out of the cells and potassium ions into the cells. So along with that, you are also going to have a electrolyte imbalance. So acidosis causes the reverse. Acidosis causes H plus to move into the cell because there's so much H plus in the extracellular compartment. It, because of the gradient, it has to go inside the cell. And when it does, in exchange, potassium comes out. So in acidosis, often is associated with, or there's a risk for developing hyperkalemia. And in alkalosis, there's a risk for developing hypokalemia. The second type, that is when there's alteration in bicarb. So you're going to see alterations in bicarb with metabolic disorders, with metabolic acidosis making. The serum bicarb is going down, less than the normal level of 22. So you'll have metabolic acidosis means pH has gone down, bicarb has also gone down, and PCO2 is also less. Compensation is respiratory alkalosis. Addition of an acid to the extracellular compartment can produce a anion gap kind of metabolic acidosis, especially seen with salicylate poisoning or some other anion which is there, which is not being measured. To compensate for this, there is also, I mean, the bicarb is acting as a buffer. There's a loss of bicarb or inability to synthesize or reclaim the bicarb, which produces a normal anion gap type of metabolic acidosis. So loss of bicarb is counterbalanced by increase in chloride ions. So bicarb and chloride are the two negative ions or anions that are there, major anions in the blood. So when you're calculating the anion gap. These are important components in the formula for anion gap calculation, where sodium levels, sodium concentration, that is the cations on one side. From that, you subtract the anions, and these are the visible or measured anions. There are other anions like acids which are there, which are being developed, but which are not being measured. So that is when you have acidosis with increase in anion gap. So this image here will show you. So this is normal plasma. Look at this thing. You have unmeasured cations and sodium. You have unmeasured anions, bicarb and chloride. So this is how normally the fraction is. In acidosis with no anion gap increase, you have again the unmeasured cation same, sodium is same, unmeasured anion is also similar. Bicarb has contracted, there's increase in chloride. So when you have normal gap acidosis or not an increase in anion gap acidosis, your chloride levels tend to increase. Whereas when you have a anion gap acidosis associated with anion gap, that means you have other kinds of acids which are increasing, which are not being measured. So the unmeasured anions are increasing. Bicarb is again small, less, chloride is again less. Right? So this is seen in metabolic acidosis with increase in anion gap. Primary alterations in bicarb, increased anion gap type of metabolic acidosis. So it causes, there's a increase in anions, different kinds of acids, lactate, salicylate, acidoacetate, all these things are causing your increase in anion gap. The excess in ions, you would expect that because the pH has gone down. It is acidosis, lactic acidosis, any kind of acidosis, and they're trying to be buffered by the bicarb, which therefore leads to fall in bicarb levels. So H plus bicarb, H2CO3, H2O, and CO2. So loss of bicarb from the buffering of H ions is counterbalanced by the lactate ions. So for every bicarb ion that is lost, there is a corresponding lactate ion to replace it. Example of an anion gap calculation would be, suppose you have a normal serum level of 130, serum chloride is 88, normal is between. So there's a fall in chloride. If you remember that image, the chloride fraction goes down in anion gap acidosis, and serum bicarb has also gone down. So if I just go back here, see chloride fraction has shrunk. Yeah, in the bicarb has shrunk. So all these things have shrunk because there is an increase in unmeasured anions, right? So you have a anion gap which is 130 minus 88 plus 10, which is 32. Normally it should be somewhere between 22 to 28, around 20. So this is an increase in anions. So this table here gives you a list of causes and how it causes anion gap or metabolic acidosis. We need not spend a lot of time here. So you have causes of lactic acidosis, how it leads to anion gap; ketoacidosis, diabetic ketoacidosis, and how it leads to anion gap; renal failure, retention of various products like sulfuric acid, phosphoric acid, uric acid leading to anion gap; poisoning like ethylene glycol, salicylate, methanol, all these poisonings lead to anion gap metabolic acidosis. So this you can read later. I'll be sharing the PPT, this one and the previous one. Then you have the third entity known as normal anion gap metabolic acidosis. Here, acidosis due to loss of H plus ions or inability to regenerate bicarb. So there's a problem mostly in the kidneys. Chloride ions tend to increase to counterbalance the reduction in bicarb ions. Again, this is what we have seen here, right? Increase in chloride ion fraction, right? So example, again, if you see sodium 136, chloride has increased slightly 110, and bicarb is again less because acidosis, any kind of metabolic acidosis, you're going to expect a fall in bicarb levels, right? So you have 136 minus 110 plus 14, giving you a value of 12, which is within your normal range, right? So it is a normal anion gap. There is no increase in anion gap over here. So Clinical findings in both types of metabolic acidosis. There is hyperventilation as a compensation. There is shock, acidosis vasodilates peripheral arterioles. Again, with in relation to the bone tend to buffer the H plus ions, causing loss of organic and mineralized bone. So in exchange of H plus, it is letting go of the calcium from the bone. Treatment, because again, if you realize when there is compensatory alkalosis or respiratory alkalosis setting in with metabolic acidosis, the ionized calcium fraction tends to go down. ट्रीटमेंट इज ट्रीटमेंट फॉर एसिडोसिस क्या होगा आपको अल्कलाइनाइजिंग एजेंट यूज करना है राइट और इन type 1 diabetes you have to give insulin as diabetic ketoacidosis has set in. Causes again diarrhea, bile acid sequestering agents like cholestyramine, drainage of bile, and then there are 2-3 types of renal tubular acidosis, which causes normal anion gap metabolic acidosis. You have type 1, which is the distal renal tubular acidosis, type 2, the proximal one, and you have type 4, the renal tubular acidosis. So all these things here it is utilizing type 4, there is utilization of the buffer which uses ammonium ions, and there are different mechanisms and different regulatory hormones are involved in all this, right? So this you can read at your leisure. Finally, coming to the alkalosis, you have metabolic alkalosis in which there is increase in bicarb, serum bicarb levels are higher, there is increase in pH, increase in bicarb. Respiratory acidosis is a compensation. Types may be in broadly 2 types, chloride responsive and chloride resistant. Causes of metabolic alkalosis include vomiting, use of thiazide toxicity, characteristic being volume depletion, decrease in serum chloride levels. So there's a reverse or inverse relation between chloride ions and bicarb ions, right? Causes of chloride resistant, causes of metabolic alkalosis under this is due to excess mineralocorticoid or primary hyperaldosteronism. There is a volume excess, and here the relation is direct. So there is increase in bicarb as well as increase in chloride. Right. So if you have alkalosis with increased bicarb, increased chloride, you want to suspect chloride resistant metabolic alkalosis. Clinical findings, again, because of all this, electrolytes are also going to get affected, increased risk of arrhythmias. Treatment by acidifying agents, spironolactone, which is an aldosterone inhibitor. Here, the main cause is excess of mineralocorticoid. ACE inhibitors are often useful, and this is how you treat metabolic alkalosis, especially the chloride resistant. Causes of metabolic alkalosis, commonest cause vomiting, makes sense. There's a lot of acid in the stomach. When you vomit, all that acid is you lose out on that acid. So there's going to be alkalosis, which is metabolic, right? Because of volume depletion, the renal threshold for reclaiming bicarb is increased. This occurs due to volume depletion. Increased exchange of H plus ions for sodium. So there are exchanges, sodium and H plus antiporter. Increase in H plus ions in urine allows for more of the filtered bicarb to be converted into CO2 and water. So these are the mechanisms. Other causes like we saw, diuretics and mineralocorticoid excess. Even iatrogenic causes like nasogastric suction can lead to metabolic alkalosis. Then finally coming to mixed acid-base disorders, there's a combination of 2 or more primary events. So how do you suspect? When you suspect it's a mixed disorder? When there's a presence of a normal pH due to a combination of primary acidosis and primary alkalosis. Example, salicylate poisoning. Salicylate is producing metabolic acidosis. It overstimulates the respiratory center, causing primary respiratory alkalosis also. If there is no respiratory center overstimulation, the pH is acidic, indicating simple primary metabolic acidosis with compensatory respiratory alkalosis. So you have a bit of both. There are formulae which will guide you. We'll see those formula one by one, which can guide you as to when there is compensation and when there is a mixed kind of acid-base disorder. Presence of extreme acidemia due to primary metabolic acidosis plus primary respiratory acidosis. So you have acidosis both from respiratory failure as well as metabolic acidosis, right? Severe vomiting, shock, and all those things often lead to this kind of scenarios. Um, so this table you can have a look where you see what are the expected pH values, the expected partial pressures of carbon dioxide and bicarb. And when you have a mixed disorder, there's primary metabolic acidosis leading to fall in bicarb, primary respiratory acidosis leading to increase in CO2 levels. So, example, cardiorespiratory arrest. Acute respiratory acidosis, uncompensated, that means carbon dioxide levels have increased. I mean, bicarb is still low. Example, CNS failure, there's depression, barbiturate poisoning. So you can't have a compensatory respiratory. Alkalosis does not set in. So this is uncompensated. Right? Chronic respiratory acidosis with partially compensated metabolic alkalosis. You'll expect CO2 values of more than 45. But here, as against this, the bicarb values are more than 30, right? So there is a partial compensation. Why is it partial? Because the pH is still acidic. If the pH had been in the normal range, then it would have been fully compensated. Metabolic acidosis with partially compensated respiratory alkalosis. Again, metabolic acidosis. Acidosis matlab bicarb less than. CO2 compensation हो रहा है, so it is getting washed away. You are not having uh, a rise in PeCO2. Like here, when it was respiratory acidosis, you can see that CO2 levels were more than 45. Here, you have CO2 levels less than 33. Example, disorders associated with increased and normal anion gap metabolic acidosis. Then again, another mixed disorder. Here, the pH is normal. See, 7.42. The PaCO2 is less, 22. So there is a metabolic acidosis, bicarb is 22, primary respiratory alkalosis because the PaCO2 is less than 33. So salicylate poisoning, septic shock, all these things. There is a component of metabolic acidosis as well as respiratory alkalosis. Due to respiratory alkalosis, there is a washout of the carbon dioxide that has happened. So similarly, these examples are there. And now we can discuss the formulae. I'll quickly go through the formulae. You will need time. You can read them at your leisure. So these are the formulae that are there. Calculations for compensations are there. Sometimes they help in identifying whether there is only one disorder or is it a mixed disorder. These are all very detailed. I'll share with you. This is from a book called Golian's Rapid Review of Pathology. I'll share the ebook also. If you want, you can go through it. There are a lot of examples over here. So you have an example of pH. What is this pH 7.2 means? Acidosis. CO2 has increased. That means there is respiratory acidosis that is there. And expected bicarb level, if the compensation is 0.10 into 74, that is carbon dioxide minus the normal level, the upper normal level of CO2. So if this is there and it increases above normal, this is the expected bicarbonate compensation. So 0.1 into the difference of the normal level, how much CO2 has increased. So if the expected bicarb compensation is, now the expected compensation should be 24 plus 3.4, that is 27.4. So the value of bicarbonate is 24 and the expected compensation in addition to that is 24 plus 3.4, that makes it 27.4. So in the patient, you see that the bicarb level is 27 milliequivalents per liter, which is the observed value, and the expected value is same. So the measured and expected or calculated bicarb are similar. Therefore, it's a single disorder, not a mixed disorder. So when there is calculation of expected compensation in chronic respiratory acidosis, you have bicarb compensation. Expected compensation is 0.4 times the difference of CO2. Again, the same formula, 0.4 into 60 minus 40 gives you 8. Expected bicarb compensation is 24 plus 8, that is 32. Measured and expected are similar, therefore again it's a single disorder. Right? Here the value is 32. Observed value is 32, expected value is 32, it's similar. So similarly, these kind of calculations are there, which helps us identify, depending on the kind of compensation, is it the expected compensation and the observed values. We understand whether it is a single acid base disorder or is it a mixed kind of acid base disorder, right? So these are the different formula which you can go through. I'm sure you don't need to memorize all this for your answers, but you should understand the principle or the logic why it is being done in such a way, right? So these are the formula for that. And finally, how do you identify mixed disorders? So you have expected PaCO2 in 1.2 into the change in bicarb plus minus 2. So again, when there is a difference in expected and observed values, the measured PaCO2 is 38, which is higher than it should be. The should be or calculated value of partial pressure of CO2 was 31, indicates that there is a respiratory acidosis or retention of CO2. That means this is present as a primary disorder. So calculating for compensation in metabolic acidosis, right? So using all this formula, we can identify when it is a primary metabolic acidosis, primary respiratory acidosis, primary respiratory alkalosis, and primary metabolic alkalosis, or is it a mixed kind of acid-base disorder? So all of these things, because we have talked about a lot of things very quickly, it may jumble up, and you would probably need to go through these slides and read the text a bit. It will help you in your understanding of acid-base disorders better. So with this, I will end and be happy